welcome to start your talk now.
Hello, good morning, good afternoon, good evening to colleagues and friends across the world. Thank you organizers for inviting me to share my thoughts on enhanced recovery after surgery, the evolution maybe from developed to developing countries. The concept of enhanced recovery originated almost 3 decades back when Professor Henrik Kellett, who's a surgeon who believed that there could be multimodal interventions that may lead to a surgical major reduction in the undesirable sequelae of surgical injury with accelerated recovery and reduction in post-operative and overall costs. As surgeons, we all want our patients to have possibly no post-operative complications and morbidity, though that is not practical. However, a reduction everybody is desirous of. Recovery, which are nothing but it's a bundle of care. They are multimodal pathways which are designed to achieve early recovery for patients who are undergoing any major surgery. It's not confined only to gynecological or gynaecological oncological surgeries, but it encompasses almost all surgical disciplines as of today. And basically, there is a paradigm shift in the concept of perioperative care that our traditional surgical practices, our perioperative practices are now replaced with evidence-based practices. And a lot of practices which were believed are good for the patients have been found to be not that good, and probably we need to discard them. These pathways, these protocols, they are comprehensive in their scope and they cover all the areas of a patient's journey. So it starts from prehabilitation, that is at the time when patient is decided for a surgery. So it starts from that time. Then it goes on to the preoperative period, immediate preoperative period, continues during the surgery, that is the intraoperative period, and then carries on the post-operative period. So the entire surgical journey of the patient is covered by enhanced recovery protocols. I'm not going to discuss the protocols per se, since my talk is about the regional variations or the problems as far as different regions of the world are concerned. The concept of enhanced recovery started long back in 1995 when colorectal colleagues introduced this concept. Then over the years, it was being called as fast-track surgery. And then in 2001, a formal study group was instituted, and that was the beginning of the ERAS Society also, which got formally initiated, installed in 2010. But the origins are almost 3 decades back now. This led on to an increased, or rather a fast uptake. However, this was more so in a formal fashion in the developed world or in the high-income countries. So you have enhanced recovery societies covering most of these regions. However, when it comes down to the low-income countries or the low-middle-income countries, the so-called developing world, there is a gap, there is a disparity. We are aware that the underdeveloped world has been battling with infectious diseases. So illnesses, infections like HIV, tuberculosis, malaria have been leading causes of morbidity and mortality in these regions. Also, there has been a huge lack of surgical care, which leads to an estimated 18 million fatalities annually in these regions. But gradually, over past 2 decades, things are improving, and now non-communicable diseases like cardiovascular illnesses, malignancies, and surgery-related deaths, they are taking a bigger and bigger toll. It is estimated by the Global Surgery, the Lancet Commission, that almost 5 billion people across the world lack access to surgical care. And surgery needs to be an indivisible and an indispensable part of any healthcare of any country. And it's not an expensive modality to be offered to the people. It saves lives and it ultimately promotes economic growth. In fact, if you look at the figures, the estimates, almost 5 billion people lack access to affordable and safe surgical care and anesthesia. This leads to a loss of almost $21 trillion in the global productivity. Almost 143 million additional surgical procedures are required to avoid these fatalities and morbidities. And this would require a huge investment of almost $350 billion globally to reach these suggested goals by the Lancet Commission. So the Lancet Commission recommended several interventions, parameters which should be instituted to reach an effective and a far-reaching global surgical services across the world. This was also raised in the 68th World Health Assembly, where it was realized by several countries and by WHO that emergency and essential surgical care programs need to be strengthened, and safe and essential surgical care and anesthesia needs to be part of universal health coverage. There has been several initiatives since then in African continent, in Asian continent, and essential surgeries, obstetric services, anesthesia services need to be strengthened. And several publications and papers are available wherein people have realized and highlighted the importance of surgical care in low and middle income countries. Similar such publications have been found where people have tried to highlight that we need to incorporate global surgery into global health. Only then we can possibly achieve a global healthy population. Enhanced recovery presents an opportunity to get all this done. How? Enhanced recovery practices are evidence-based approaches. Once we incorporate these evidence-based approaches and a standardized perioperative care, it ultimately leads to cost benefits. And everything ultimately boils down to cost. Since the issue is cost in most of these regions, incorporation of enhanced practices will finally lead to these benefits and cost savings and an economical investment, I would say. This was highlighted by a recent meta-analysis that enhanced recovery after surgery has been found to reduce the length of the stay, complications, and the cost of care without any increase in the rates of readmissions or mortality. This paper was especially to our practice. However, similar papers and similar evidence exists in all surgical disciplines today. We had conducted an international survey recently wherein we found that across globe, the implementation and incorporation of ERAS protocols in Asia and Africa are the lowest. So there is a requirement and there is an urgent need to incorporate these practices. Only 19% and 10% was the report that ERAS was being implemented in Asia and Africa. Things are not that bad. There have been several initiatives, and a lot of people are now doing research and doing ERAS work in these regions. So you have studies from Africa, you have studies from India, South Africa, from UAE. So it is being increasingly adopted. If you look at formal institution or recognition of enhanced recovery after surgery centers, till 2016, there were only 2 such centers that were existing in Asia. One was in Philippines and was in Singapore. However, there has been an improvement. Singapore hosted the Asian chapter of Enhanced Recovery International Meet in 2019. China got its first ERAS Society affiliated hospital last year in August. Similar changes have been seen in the Latin American region. In fact, they have a Latin American chapter of the Enhanced Recovery Society. They have a project ECERTO, which has been running for some time, and they have found that there are benefits in the perioperative morbidity and mortality. Thus, there is a benefit, and this has been proven across different populations and different regions. There are more hospitals, more centers in Latin America that have incorporated, that have instituted enhanced recovery as formal programs in their institutes and hospitals. And more are getting added as we speak. Briefly talking about what are these challenges when we talk about the developing world. Why is the developing world lagging behind? I mentioned that there is a general lack of access to good surgical care, safe surgical care in lot of these regions, especially the rural setups. There are many places which does not have even a safe cesarean facility or a safe anesthesia facility. So how would one go on to enhance recovery? The healthcare infrastructures are constrained for resources in many of these regions. Nutrition, which plays a huge role as far as recovery from any surgery is concerned, is itself an underlying problem, with malnutrition rather prevalent. Cost, ultimately it boils down to cost, since a lot of these regions are not able to spend a significant amount of their GDP on healthcare. So a very minuscule percentage of that finally boils down and reaches the surgical care. And the healthcare facilities which are existing even in the urban setups, they are overburdened and overstretched. We often see our outpatient clinics running in hundreds, our emergency services overburdened, our inpatient services overburdened. So there are many problems. Just briefly about what exactly does it cost as far as implementation of an enhanced recovery. If one institute were to formally incorporate an enhanced recovery protocol or program, several people are required for that. Any enhanced recovery program requires 3 key people. So the surgeons, PR, you require an anesthetist, and you also require an ERAS nurse. So these are the 3 key pillars or 3 champions of enhanced recovery program. Of course, employing an ERAS nurse would cost some money. Then whatever data that is generated after this program is instituted, you require somebody to capture it. Again, an individual. You require some kind of system, so some kind of software to capture all that. That is going to cost some money. You require some administrator to manage all this new manpower and all this infrastructure. You require constant education and updates and training and an ongoing research to study the outcomes of these programs that have been instituted. There has to be regular meetings as to what are we going correct, are we doing things correctly. And if one were to institute the formal ERAS program, it requires an audit software. An audit is finally required to study the outcomes. This software is expensive. So there are cost factors involved. However, probably in long run, these cost factors turn out to be cost effective. In fact, there was a Canadian study where it was found that each dollar spent on an enhanced recovery program saves $4 after a while. So there is an initial investment, however, it turns to cost benefits. Certain other problems that probably exist in the developing world is that most of these places do not have formal preoperative clinics where one could hope to optimize patients preoperatively, which is an essential factor if one were to have an enhanced recovery and an early recovery and less of complications. Early discharge is a very important factor of enhanced recovery program. However, is early discharge feasible in these regions, the low middle income countries and the developing part of the world? Probably not all the time, because a lot of these patients who travel from rural areas or from small towns, they travel to the bigger cities or the bigger hospitals or the secondary or the tertiary level hospitals, where everything is out of pocket expenditure. They may not be covered by a formal insurance. Formal insurance is lacking in most of these regions. So ultimately, it would be much more costly for the patient to go home early and then keep coming back, maybe for a follow-up. So patients choose to stay in the hospital till they have recovered well, or they have recovered enough that they feel they are now really fit to go back. So early discharge sometimes is not a practical feasibility. Another huge issue probably is the surgical practice, which is based on experience or so-called eminence. The senior members of the surgical teams, the anesthesia teams, they probably are not as receptive to the emerging concepts. They are not probably as receptive to evidence-based medicine or evidence-based practice, and that could be an inhibitor, that could be a barrier to implementation of enhanced programs. And finally, it all boils down to probably a lack of political will. We are aware that for any health program, for any intervention at a national level, the politicians or the healthcare administrators at the highest level need to intervene and need to bring about those changes, because they are the ones who are going to approve as far as these additional costs are concerned. So there is a lot to be done. What could be the possible solutions? I have cited so many problems. So this was in a recent chapter that we need to start from the basics, from scaling up the basic surgery facilities, improving our preoperative services, standardizing our preoperative plans, probably instituting systems to collect our data of the surgeries, the perioperative outcomes, and finally, maybe we are ready for enhanced recovery program implementation. There is level 1 evidence available now, and it's high time that enhanced recovery practices are being practiced and incorporated. Much more so now that most of the world has suffered a surgical backlog because of the COVID-19 forced lockdowns and barrier to elective surgeries. So many elective surgeries were